Today's lecture, inshallah, will be about the introduction of to Protozoa and Giarrdia Lamblia. My name is Dr. Fadwa Arafa, and I am a lecturer of medical parasitology. The lecture is divided into two parts. The first part is about the introduction. It's a very small part, and we will start by dividing the protozoa into different phyla according to their classification. This classification is done according to the different organ of locomotion and according to the type of multiplication. The phylum Sarcomastigophora, phylum Celiophora, and phylum Epicomplexa. And then Sarcomastigophora is further subdivided into two subphyla, Sarcodyna or amoeba, and Mastigophora or the flagellates. What about the phylum Sarcomastigophora? As we already said, it is subdivided into two subphyla, Sarcodyna or amoeba, and Mastigophora or flagellates. Sarcodyna, the trophozoite move by the aid of pseudopodia, and the method of reproduction is through asexual reproduction by binary fission. The members to be studied in this module are the entamoeba histolytica and the commensal amoeba, while the Mastigophora, the trophozoite move by the aid of flagella, and asexual reproduction occurs by longitudinal binary fission. And the example here is Giarrdia Lamblia, which is the second part of this lecture. The two other phyla are the phylum Celiophora or the ciliate and phylum Epicomplexa or the coccidia. Phylum Celiophora, here the trophozoite moves by the aid of cilia, and they divide either asexually by binary fission or sexually by conjugation. And the example here in the GLT module is Valentidium coli. While phylum Epicomplexa or coccidia, they possess an apical complex. That's why they are called epicomplexa. This apical complex aid in the penetration of the host cells, but no definite organ of locomotion. Here they multiply by means of either sexual multiplication or gametogony, and asexual multiplication through schizogony. The members to be studied in this module are Isospora belli and Cryptosporidium species. Let's start with the second part of this lecture, which is the Giarrdia Lamblia. The Giarrdia Lamblia is one of the most common intestinal parasites. It usually occurs in as a family or group disease, where in endemic areas where where it is transmitted orally. It could occur also as an in epidemic form through the polluted water. It's more common in children. Geographical distribution is cosmopolitan, but it is most common in tropical and subtropical countries. As regards the habitat of the parasite is mainly found in the crypts of the duodenum and upper jejunum. The parasite could also be occasionally found in the bile ducts and gallbladder. Here we can find the trophozoite of Giarrdia Lamblia in the small intestine. What about the morphology? The parasite exists in two forms, the trophozoite or the vegetative form and the cyst form. Here the form which is responsible for the multiplication and reproduction is the trophozoite, and as we already said, it's a member of Mastigophora or the flagellates, and it multiplies by longitudinal binary fission. What about the morphology of the trophozoite? The trophozoite is bilaterally symmetrical. As you can see, it is bilaterally symmetrical and pear-shaped, broad anteriorly and tapering posteriorly. Its size ranging from 9 to 21 micrometers by 5 to 15 micrometers. Here you can see that the parasite has dorsal surface and a ventral surface. The dorsal surface is convex, while the ventral surface has an anterior ovoid concavity, which is called the sucking disc. The sucking disc serves for the attachment of the organism to the mucous membrane. Here you can see the dorsal surface, which is convex, and here the ventral surface. The anterior part of the ventral surface is ovoidal, has ovoidal concavity called the sucking disc. Here the sucking disc serves for the attachment to the intestinal cells. There are two vesicular nuclei which are observed in the area of the sucking disc. This is the sucking disc, and here are two vesicular nuclei. There are 4 pairs of flagellae. The first pair, the second, third, and fourth pair, plus 2 sausage-shaped median bodies which are posterior to the sucking disc. The other form in which this parasite exists is the cyst form. The cyst is oval in shape, about 8 by 14 micrometer in size, and it contains 4 nuclei. These 4 nuclei are usually located at one pole. There are also the para-basal bodies, remnants of flagellae, and axoneme. How are we infected by this parasite? We are infected through ingestion or swallowing of the cyst, which could be through the contaminated food and the drink, through the direct infection from man to man, auto-infection, or through mechanical transmission by house flies. The infective stage here is the cyst form. This is the cyst, oval cyst, 4 nuclei at one pole, and here are the remnants of flagellae and exostylin parabasal bodies. Here this form, the cyst form, is the infective stage. When we ingest it with contaminated food and drink, it exists in the duodenum. Excitation occurs in the duodenum, and the trophozoid form is released. These trophozoids multiply by longitudinal binary fission, which means they are separated the longitudinal axis. Each trophozoid gives rise to 2 trophozoids. These trophozoids will multiply and cause the clinical picture. And when the trophozoid passes with the stool and it reaches the colon, the liquid feces becomes dehydrated, and this triggers the intestation. This trophozoid will form a tough cyst wall around it to protect it, as it senses the changes in the environmental condition. However, in cases of severe diarrhea or frankly diarrheic stool, there might be no time for the cyst formation, and therefore it is usual to also find the trophozoids. Another photo of the life cycle. Here, ingestion of the cyst is followed by excitation in the duodenum, and the trophozoid emerges, longitudinal binary fission, and these trophozoids are responsible for the symptoms. Excitation occurs when the stool reaches the colon, and in case of diarrhea, not only the cysts are also the trophozoid can be expelled in feces, and these cysts only can survive. The trophozoid cannot survive in external environment. These cysts are responsible for the infection and the continuation of the life cycle. Another photo of the life cycle. Here, the cyst exists and trophozoid is released. It is here, it replicates on the mucosa, and when it reaches the colon, it starts incestation to form the cyst, and the cycle continues. The cyst exist and the trophozoite multiply on the intestinal surface, and with the multiplication and increased number of intestinal trophozoite, the symptoms will appear and increase in severity as the time passes. And then when the trophozoite reaches the end of the intestine and the colon, and this will trigger the formation of the cyst, and the cyst or the infective stages will continue the life cycle. What about the clinical picture? How the patient is presented? In a good percentage of infected people, they are completely asymptomatic. However, if it is symptomatic, it can be presented as in the form of diarrhea, dyspepsia, or malabsorption. In symptomatic cases, the incubation period lasts from 1 to 3 weeks, and the disease presents in different forms. As we already said, the first form is the diarrhea, which could be of acute or gradual onset. The stools are usually offensive and pale yellow and frothy, similar to lentil soup. In addition, it could be also presented in the form of dyspepsia, where there is epigastric pain, marked nausea, and flatulence. Finally, it could be presented as malabsorption. In case of severe infection and severe diarrhea, there is also weight loss, lassitude, and fatty stool in the form of steatorrhea. This steatorrhea occurs because of the diminished intestinal absorption of fatty acid. There is also malabsorption of D-xylose and vitamin B12. It is very important to understand the underlying mechanism of the malabsorption which occurs in case of diarrhea. It's a very, very important point. First, here you can see these are all Giarrdia trophozoite. You can see they are pear-shaped with flagellae, and this is the dorsum of all of these Giarrdia trophozoite. They are attached by the sucking disc to the surface of intestinal mucosa. With a large number of Giarrdia trophozoite, they will block the mucosal cells due to their attachment by the sucking disc. They will prevent the absorption of different nutrients. This is the first mechanism for malabsorption. The second mechanism is also due to inflammation of epithelial cells, which hinder their absorptive function. Therefore, will be unabsorbed fatty acid will accumulate in the intestine, and this will give the stool the pale yellow frothy appearance, or the lentil soup, as we already said. How could we diagnose this infection? For diagnosis of intestinal parasite, we could use either direct methods or indirect or immunological methods. The direct methods could be through stool examination, duodenal aspiration, or enterotest capsule. The direct methods, the first method is the stool examination. If the patient is presented with diarrhea and the stool is diarrheic, the main form that you will find in stool is a vegetative form. If you take a small stool sample and put a drop of saline on it, then cover it with the cover slide, examine under the microscope, you will see this stage, which is the trophozoite stage, pear-shaped, 2 nuclei at one pole. Here, it is diarrheic stool. If the stool is well formed, so you will find the cyst stage. This is the oval cyst and could be visualized by the use of Lugol's iodine solution. Here we put a drop of Lugol's iodine on the stool and examine it under the microscope, and the cyst will be stained light brown like this one. In all cases, do we see the trophozoite or the cyst? No. Sometimes repeated stool examination should be done because the organism tend to pass in the stool intermittently. So we have to examine 3 samples on alternate days to make sure if the infection is present or not. In scanty infection also, we can concentrate the stool sample by using a flotation method. It's called zinc sulfate flotation method. How it is performed? This method is performed by using zinc sulfate, which is of high specific gravity. Mixing it with stool will separate the Giarrdia from the stool debris. The Giarrdia will float to the upper surface of the zinc sulfate, which can be taken and examined under the microscope. Here we concentrate the parasite. This method is called zinc sulfate flotation technique. The second direct method for diagnosis is the duodenal aspiration. If we did stool examination repeatedly and we did not find the parasite, and still there is clinical evidence that it is Giardial infection, but repeated stool examination was negative, we might perform duodenal aspiration, because as we already said, the parasite is excretion might be erratic and not regular, might be intermittent. The third direct test is the Entero test. Entero test capsule or duodenal capsule test. This is a method for examination of the duodenal contents. As we already said, the habitat of the Giardia parasite is in the duodenum and upper duodenum. We can use this device to understand examine the duodenal contents. The device consists of a nylon thread and a gelatinous capsule. The patient swallows the capsule, and the thread which protrudes from one end of the capsule is fixed to the side of the patient's face. As you can see here, this is the capsule and this is the nylon thread. Here the capsule and the thread from one end. The patient swallows the capsule and the thread is taped on the side of the patient's cheek. The capsule is swallowed and left in place for 4 hours, and then the thread is pulled out and you will find the bile stained mucus attached to the capsule. It will be scraped off and put in a petri dish. This scraping is examined under the microscope, and if it is Giardia infection, you will find the parasite in this duodenal content scraping. What about the indirect method, the immunological method? Here also, if the stool examination did not reveal the parasite and the clinical picture is also suggestive, we can detect the Giardia Lamblia coproantigen by using ELISA technique. How do we treat this disease? By using metronidazole or flagyl. It is important to prevent the infection, and it is also easy to prevent. Proper environmental sanitation is important. Proper water supply, filtered water, and proper sewage disposal system. It is also important to carefully clean the hands and vegetables. Washing your hands and vegetables will prevent the infection by the cyst stage. And here the personal hygiene is of great importance in preventing the infection. We have to avoid use of human excreta as soil fertilizers. As we already said, the cysts have to, which exists in the stool, have to contaminate the food or drink, and if we use them as soil fertilizers, the cyst will exist in our food and will continue the cycle. We have to protect the food from house flies, which mechanically transmit the cysts. And finally, treatment of patient is very important. Thank you.